Sayın Dekanım, sayın hocalarım, değerli konuklar ve sevgili katılımcılar, Medisep öğrenci topluluğu olarak bu yıl organize ettiğimiz Medisep Afet Sempozyumuna hepiniz hoş geldiniz diyerek başlamak istiyorum. Bu Afet Sempozyumu biz çalışmalara başladığımızda yapmayı en çok istediğimiz, ilk kesinleştirdiğimiz hedeflerimizden birisiydi. Bunun birden çok sebebi var aslında. Gerek hazırlık süreci, gerek süreç yönetimin, gerekse tanımının çok geniş olması sebebiyle afetlerin ayrıca işlenmesi ve toplumda daha fazla bilinç kazanılması gerekiyor. Ve bizler de sağlık çalışanları adayları olarak aslında ileride bu konu hakkında değişik yerlerde değişik sorumluluklar edinebiliriz ve ediniriz. Biz Medisep olarak buna inanıyoruz. Bu sebeple önceden bu konu hakkında bilinç kazanmak, eğitimimiz sırasında bu konu hakkında çalışmalara başlamanın çok önemli olduğunu ve bu konunun toplumumuzda da daha ileriki düzeylerde de işlenmesi gerektiğine inandığımız için bu 2 günlük sempozyum organize ettik. Değişik bakış açılarını yakalayabilmek ve bahsettiğim bu geniş kapsamı daha iyi anlayabilmek için ülkemiz ve dünyadan değişik katılımcılar ve birçok oturum hazırladık. Umarım verimli 2 gün geçirirsiniz ve istediğiniz verimi sağlayabiliriz beraber. Diyerek kendi ricası üzerine ilk konuşmayı Tıp Fakültesi Dekanı Sayın Bülent Altun'a.
Çok teşekkür ediyorum Elifciğim. Benim başka bir toplantıya katılımım gerektiği için saat 11'de bir oturum başkanlığım var. Sırayı biraz bozma, programı bozduğum için de özür diliyorum. Öncelikle katılan tüm öğrencilere, öğrencilerimize, misafirlerimize, değerli hocalarımıza, konuşmacılarımıza çok teşekkür ediyorum. Bu sempozyumu aslında Medisep'in yaptığı daha önceki sempozyumlarla birlikte düşündüğümüzde şu aklıma geliyor. 5 yıllık dekanlığım süresince devamlı olarak sosyal hesap verebilir bir tıp fakültesi ve tıp eğitimini hedefledik. Bu bağlamda sadece tıp öğrencileri değil, tıbbın dışında örneğin öğretmenlerimize tıpla ilgili eğitimlerin verilmesi, çocuk sağlığı ile ilgili gibi uygulamalar oldu. Tabii tıp eğitimi müfredatında da bu yönde değişiklikler yapıldı. Ama toplumun sorunlarına, coğrafyanın sorunlarına yönelik eğitimin desteklenmesi gerekiyor. Çünkü müfredat çok yoğun. İşte bu bağlamda yıllardır sempozyumlar yaparak bize destek veren Medisep öğrenci topluluğuna çok teşekkür ediyorum. Hep yaptıkları sempozyumlarda toplumun sorunlarına çözüm önerileri getirecek şekilde ve tıp öğrencilerinin bundan haberdar olacak şekilde planlamalarından dolayı başta Sayın Başkan Elif'e ve tüm yönetim kuruluna emeği geçen herkese çok teşekkür ediyorum. Bu teşekkürüm sadece bu sempozyum için değil, şimdiye kadar yapmış oldukları uygulamalardan dolayı. Tabii burada liderlik yapan hocalarım da burada. Kemal Hocam, Şahin Hocam, Melih Hocam da burada. Dolayısıyla Medisep'e genel bir teşekkür etmek istedim bu bağlamda. Bugünkü başlık açısından da ayrı bir teşekkürüm var. Çünkü ben bir nefroloğum. Nefrolog Luigi biliyorsunuz depremle ilişkili olarak afet tıbbının göbeğinde oturan bir noktada. Elif de açılış konuşmasında vurguladı aslında. Hepimiz bir yerlerde görev alabiliriz dedi. Bu çok önemli. Saat 12'de Mehmet Hocam anlatacak. İstanbul depreminden sonra Türkiye'de Nefroloji Derneği olarak, nefrologlar olarak eylem planları geliştirdik, eğitimleri arttırdık ve bu şekilde her deprem olduğunda da nefrologlar bölgeye gittiler. Bu ilk başta ulusal çaptayken zaman içinde uluslararası çapa ulaştı. Dolayısıyla bu olaya sadece tabii coğrafi bölge olarak bakmamak lazım. Her hekimin COVID-19 pandemisi de gösterdi ki afetler konusunda bilgi sahibi olması gerekiyor. Bugün bizim hastanemizdeki uygulamadan örnek vererek buna bir atıfta bulunayım. Erken dönemde COVID-19 ile ilgili ana bilim dalları görev alırken zaman içinde tabii ki sağlık çalışanlarında doğan yorgunluk ve eğitim kaygısı nedeniyle bugün hem Ankara İl Sağlık Müdürlüğü'nün nezdinde filyasyon çalışmalarında hem de hastanemizde tüm ana bilim dalımızın araştırma görevlileri görev alıyor. Dolayısıyla gelecek olarak da bakmadan Allah uzak etsin yaşanabilecek çok büyük çaplı bir afette şu anda ülkemizde 150 bine yakın olan hekimin yanı sıra yine yaklaşık 90 bine yakın tıp öğrencisine insan gücü olarak ihtiyaç da doğabilir. O nedenle sadece hekim olarak değil, aynı zamanda tıp fakültesi öğrencileri olarak ki biz sizi her zaman meslektaşlarımız gibi görüyoruz, meslektaşlar olarak görüyoruz. Bu eğitime daha tıp fakültesi aşamasında derinlemesine sahip olmak ve yarın öbür gün yaşanacak bir büyük çaplı afette hekim abileriniz, ablalarınızın yanında da görev almanız gerekebilir. O nedenle bugünkü sempozyum gerçekten çok anlamlı. Bunun için de emeği geçen herkese, konu başlığını bulan arkadaşlarımıza çok teşekkür ediyoruz. Konunun önemini zaten COVID-19'da yaşadık ama sonrasında Ekim ayından itibaren işte Sığacık'ta yaşanan, ardışık gelen depremler, yakın zamanda hortum gibi olaylar gösterdi ki bizim bu konuya çok daha derinlemesine bakıp eğitim planlarımızda yer vermemiz gerekiyor. Ben sözü çok daha fazla uzatmak istemiyorum program akışı nedeniyle. Ben tüm Medisep ekibine, onların danışman hocalarına, Melih hocama, burada davetimizi kırmadan gelen tüm ulusal ve uluslararası konuşmacılarımıza çok teşekkür ediyorum. Ve sempozyumun başarılı geçmesi dileğiyle saat 12'ye kadar aranızdan ayrılıyorum. 12 sonrası tekrar oturumlara katılacağım. Tekrar teşekkür ediyorum sıralamadaki değişikliği yaptığı için de Elif'e kolaylıklar diliyorum.
Teşekkür ederiz Bülent Hocam. O zaman bir sonraki konuşma için sözü öğretim görevlisi Doktor Şahin Hanalioğlu'na devrediyorum.
Herkese günaydın. Elif, ben de senin şahsında bütün Medisep Yönetim Kurulu'na ve Medisep üyesi arkadaşlara bu nazik davetleri için teşekkür ediyorum. Bülent Hoca çok güzel bir şekilde aslında ifade etti. Oldukça önemli bir konuyu çok önemli bir zamanda gündeme getirmişsiniz. Tıp öğrencisi arkadaşlarla bu konuyu derinlemesine inceleme fırsatı yaratmışsınız. Ben de kendi böyle programı incelerken böyle 15 yıl öncesine gittim. Ben de tam böyle 15 yıl öncesinde Medisep'in başkanlığını yapmıştım. Şimdi beyin cerrahisinde öğretim görevlisi olarak tabii biraz aradan geçen sürede sanki uzak kalmışım gibi görünse de hala çok hatıralarım çok canlı. Bülent Hoca konuşurken aklıma geldi. Biz de çok yakın zamanda hani konunun önemini arkadaşlara anlatmak adına söylüyorum. Yakın zamanda bir Türkiye'deki beyin cerrahi asistanlarının eğitiminin COVID sürecinden nasıl etkilendiğini ortaya çıkmaya başladı. 80'den fazlası bir şekilde COVID polikliniklerinde, servislerinde veya yoğun bakımlarında görev almış. Bu da şu demektir, bitirdiğiniz zaman ben beyin cerrahisine girdim, artık diğer branşlar beni ilgilendirmiyor. Böyle konular, genel tıpla ilgili konular ya da afetle ilgili konular beni ilgilendirmiyor diyemiyoruz. Hiç beklenmedik bir şekilde bütün bir 2020 yılını bambaşka, hiç hayal etmediğimiz bir şekilde geçirmek durumunda kaldık hepimiz. Dolayısıyla birer tıp öğrencisi olarak hepinizin de bu durumlara hazırlıklı olması gerekir. Bu sempozyumda bu açıdan önemli bir öğrenme fırsatı olacaktır diye düşünüyorum. Ben de nazik davetiniz için tekrar çok teşekkür ediyorum. Bütün hocalarımıza, konuşmacılarımıza teşekkür ediyorum. Medisep adına da, fakültemiz adına da. Ve verimli, keyifli bir sempozyum olmasını diliyorum. Çok teşekkürler.
Teşekkür ederiz. O zaman şimdi de bir sonraki konuşma için sözü doçent doktor Kemal Mehmetoğlu'na devrediyorum.
Herkese günaydın. Medisep'in işlerinin kalitesini artık hiç, yani gözüm arkamda değil, harika işler çıkarılıyor burada artık. Yani bu arka planın düzen, yani çok detay işler bile mükemmelle ulaşmış durumda. Gerek çıkardıkları dergi, gerek yaptıkları genel kurul, işte her toplantısı gerçekten harika. En ince detayına kadar düşürülmüş toplantılar. Afet Türkiye'nin bir gerçeği, yani afet dünyanın bir gerçeği aslında. Çünkü aslına bakarsanız yaşamak risktir. Yani ölürsek bir risk kalmayacak, hiçbir sıkıntı kalmayacak. Dolayısıyla yaşamak riskli olduğu için afetlere de hazırlıklı olmak kesinlikle gerekli. Gerek bu iklim değişikliğinden dolayı karşımıza gelen, İşte ısınmadan dolayı gelen iklim değişiklikleri, gerek deprem, bunların hepsi bizim bu konuyu da ele almamızı gerektiriyor. Bu arada tıp fakültesi öğrencilerinin de tıp fakültesine bu şekilde destek veriyor olmaları da çok güzel. Çünkü yani sonuçta şöyle düşünelim, hani hepimiz aslında bir olay için uğraşıyoruz. Yani mesela hükümet var, bir de bu işte NGO'lar var, değil mi? Hani burası da aslında, şimdi tıp fakültesi var. Her şeyi oradan bekleyemeyiz. Bir de tıp fakültesi öğrencilerin kurduğu topluluklar, onların katkıları çok değerli. Tıp fakültesinde bize verdiği katkılar çok değerli ve yardımlar. Böyle çok senkron, mükemmel bir nasıl söyleyeyim, melodi yakalamış durumdayız. Tıp fakültesi mesela bu 300 kişilik Zoom'u bize desteğini vermiş. Muhtemelen davetli konuşmaların davet edilmesinde de önemli yardımları vardır. O yüzden herkese teşekkür ediyorum. Katılımcılara teşekkür ediyorum. Elimden geldiğince toplantıya katılmaya çalışacağım. İyi toplantılar diliyorum. Ekibe de alkış.
Teşekkür ederiz Kemal Hocam konuşmanız için. O zaman açılış konuşmasını yapmak için Sayın Profesör Doktor Melih Elçin'e şimdi sözü devretmek istiyorum.
Merhabalar, hepinize günaydın. Gerçekten elinize sağlık. Çok güzel hazırlanmış bir program. İlk fikir ortaya atıldığı andan itibaren çok heyecan vericiydi ve elimizden gelen gayreti, desteği vermeye çalıştığımız bir süreçti. Şimdi baktığımızda tıp fakülteleri programları ne yazık ki, ben bunu hep söylüyorum, çok hastalık temelli ve yine ne yazık ki bazen çok da o alanda çalışsak bile o alanın bile daha ayrıntılı bilgilerini öğrenmek durumunda kaldığımız ama hayatımızın her anında karşılaşabileceğimiz bugünkü gibi afet ve acil durumlar gibi konuların aslında biraz daha geri planda kaldığı eğitim programlarına sahibiz. Bir dönüşüm yaşamamız gerekiyor. Ama şu an bunu yaşayamadığımıza göre, bu eksikliklerle programımızı devam ettirmek durumunda kaldığımıza göre bu yaptığınız çalışmalar, bu yaptığınız müdahaleler çok daha önem kazanıyor. Özellikle bu şekilde meslekler arası ya da disiplinler arası işlerin yapılması gerektiği yerde çok eksiklerimiz var ve sizler öğrenciler olarak bunu görüyor olmak, bunun boşluğunu bu tip çalışmalarla doldurmak için çaba sarf ediyor olmanız da çok değerli. Bu çabalarınızın şimdiye kadar hep örneklerini gördük. Bundan sonra da örneklerini göreceğiz. Bunlar aslında birer kıvılcım. Bu kıvılcımlar belki de programlar içerisindeki değişikliklere de yol açacak. Buradan elde edeceğimiz sonuçlar bizim tıp eğitimi programlarında karşılık bulacak Bülent Hocam söyledi, zaman içerisinde yapılan birçok bu anlamdaki çalıştay ya da araştırmalar tıp fakültesinde programa dönüştü zaman içerisinde, son 5 yılda özellikle. O yüzden umarım bu sempozyumda önümüzdeki günlerde program içerisinde bir temsiliyet kazanır. Gerçekten tıp eğitiminde çok büyük eksiklik olduğunu düşünüyorum. Çünkü acil ve afet durumlarının gelişmişlikle bir ilgisi yok. Yani bugün işte şu anda Amerika'da, Teksas'ta insanlar kar nedeniyle bir afet durumu yaşıyorlar. Elektrikleri yok, suları yok, haberleşemiyorlar, ulaşamıyorlar hiçbir şekilde. Bir bakıyorsunuz başka bir yerde bir anda bir Japonya'da bir deprem oluyor, yollar yıkılıyor, göçüyor. O kadar hazırlıklı olan bu alana yatırım yapmış olmalarına rağmen. Bu gibi nedenlerle bu yaşadığımız pandemide de görüldü ki dünyadaki alışkın olunan ya da görmeye alıştığımız son zamanlardaki hastane temelli sağlık hizmet modelleri çöktü. Bu nedenle hastane temelli bir sistemimiz olduğu için pandemiyi yönetmekte çok zorlandık. Büyük açıklar verdik. Sağlık insan gücümüz tükendi. O nedenle bakış açımızı değiştirecek en küçük hamle bile çok değerli. Bu çalışmanızı da yürekten destekliyorum. Umarım çok güzel, verimli bir toplantı olur. Hepimize kolay gelsin.
Çok teşekkür ederiz Melih Hocam. From now on, we are currently in the first session of our symposium, and the session was supposed to start in 5 minutes, but if it's in order for all the participants, we may start 5 minutes early. And I would like to ask Mr. Ingrassia if it's okay for him if we started a couple of minutes early than planned.
Good morning. I hope you can hear me. And I would say yes, I have no problem. I'm very happy to join and start as soon as you would like.
Okay, then. Before we begin, I would like to address our current speaker. It's a great pleasure for me to introduce our speaker of the first session, Pier Luigi Ingrassia. Mr. Ingrassia is the Scientific Director of Simulation Center in Centro Professionale Sociosanitario, Lugano, and he was elected Secretary of Society for Simulation in Europe in 2019. He began his career at Italian NHS hospitals as a resident in anesthesiology and intensive care, and then he developed an interest in emergency medicine and disaster response. He is the co-founder of the Research Center in Emergency and Disaster Medicine at the University of Eastern Piedmont. He served the regional office for Europe for WHO as technical officer in emergency medical systems. On behalf of the organization committee, I would like to thank Mr. Ingrassia for his presence. And before we begin, I would like to ask him officially if it is okay for him, for us to record this meeting. If it's in order, we are going to record this session and we may upload it to our websites afterwards so that the fellow students of our faculty and the other teachers may also reach the contents of our symposium.
Yes, I'm in favor for the recording, no problem.
Okay, thank you very much. And you, now I yield the floor to Mr. Ingrassia.
Thank you very much. And good morning to all the participants who are joining this such an important event. I have to say that, honestly speaking, I'm very honored to have been invited to this symposium, and I would like to thank my friend Melih for the invitation, Dr. Elchin, and the whole organizing committee for the opportunity to, share with you some of my thoughts and some of the experience that I gained in the last years. So thanks from the heart. So I don't have to. I mean, I don't have any conflict of interest. This is my first disclosure. So the instruments and the tools that I'm going to present are simply example of what the simulation market offer or what is available in the market regarding the simulation instruments. But I have to do another, another disclosure, another statement. So my little daughter, tonight, decided at 3 a.m. to, join her parents and play toy. So I have to confess that probably my superior cognitive function now are a little bit impaired, and especially my language skill, and probably this talk won't be elicited amongst the greatest speeches of the decades. So please forgive me, but my daughter decided to go back to sleep at 6:50 a.m. So I apologize for the consequence that this could have on my brain. By the way, so the topic that I was assigned to talk about. It's quite wide, and I decided to structure my my speech in the way you can see in the slides. So we are trying to together set the scene. Identify what we're talking about and why we're talking about education. And then I'm going to make some example of either the instruments, the modalities, and the opportunity that students, and I would say health professionals instead of students, can have when they want to approach the disaster medicine field. And finally, we're going to do a kind of sum up and recap. So I was kindly presented. I don't add anything else. But this conversation that we're going to have, it's mainly the result of my experience in the field, either of the preparedness and response in disasters and crisis situation. I have the chance to collaborate with different UN agencies, but also at the national level. And it's also the result of my experience in the field of education, being in charge of a simulation center and research center in emergency and disaster medicine. So I'm going to share with you the experience that I achieved, that I collect in recently in the Centro di Simulazione in Lugano, Switzerland, where I've been working since November, but also the experience and lesson learned in the simulation center in Novara, in the University of Eastern Piedmont, in Simnova, and I think the majority of my talk will be based on on what we have done, and we still do it at the CRIMEDIM, the Research Center in Emergency and Disaster Medicine, again in the Novara University. So some of the examples that I will report to you are based on what we have shared there. So, and I try to, to go through the topic, posing some question to all of us. So very simple question using, why, when, how, and who is going to teach, and to whom we are going to teach. So my first question is, why training? Why we have to talk to training, and why the first topic of this symposium is dedicated to education to healthcare workers. Actually, because it's a long ago that someone started to talk and to invite the scientific community to teach disaster medicine and disaster management principles to civilians, to the to physicians and to the healthcare. It was in 1966 that the first editorial was published in the JAMA, and Dr. Brown invited to take experience from the two previous world and to use this experience to teach the the healthcare providers in how to manage extraordinary situation, which by definition are the disaster and the mass casualty events. So it was long ago that this was highlighted, but unfortunately, I think at least in I would say in my country, we have not been keen enough to get this invitation. So I jump to the recent years, and we recently did a study. We actually asked inquired physician working in ED, in emergency department, and we asked what they know about emergency, what they know about hospital disaster management and disaster management in general. Shame to say that the strong majority, but really the strong majority, had no idea what a hospital disaster preparedness plan or management principle actually were. And this is a little bit, so this in a way scared us. This occurred, of course, before the pandemic struck Italy first, and then the entire Europe later afterwards. So we have this big gap, and so the workforce is still unprepared. So we interview all the level 2 emergency department in the country. And why this occur? So that was the question that that came in our mind, and actually. We in a way expected that this result, because some years earlier we interviewed the Italian medical students, and just to ask whether they had never ever exposed to disaster training in the medical school, and the result were very bad as well. So the majority of them had never been exposed to any specific training in disaster medicine, either academic nor otherwise. So this means the junior physician, the junior healthcare provider had no, I would say, knowledge, no practical skills on how to manage this situation. And so this is actually not an Italian issue, because that was the following question. It's only Italy that are facing this situation. It's, more extended, is worldwide. So we did, we researched, and we saw that before us, other people have reported the same situation. This was published regarding the U.S. medical schools, but then it came to us that a lot of other country have been facing, I mean, the same situation, either the Netherlands, China, Pakistan, and many others. Germany, the last one that we contributed to. So it was kind of general big problem. And but that's also what it caused that, and we gave evidence to that at the international level, what the health professionals complain or are claiming is that they are facing deficiency in terms of knowledge and abilities in how to deal with such events. And this was in a way addressed again based on evidence and reported to the scientific community. And this had the result. I mean, this had a dramatic result and outcome. And if we look at what was carried out in previous disaster response events, actually the situation is warning, because was highlighted was, I mean, make evident that the healthcare provider who were deployed in such countries to, in theory, provide help actually caused damage to the population. Because again, we could be a very good physician, we could be a very good doctor in our, I mean, environment where we're used to work, but working in a tent, in the middle of nowhere, where no diagnostic facility are attached to us, it's another thing. So we have to switch our mind and our professional way to work. So that's why I would say it's important to make the train. And what is the situation currently in my country, especially? That's again, I report my personal experience first, but also at international level. So how we can train? That's the following question. And I would take advantage from this review that was done by a friend of mine, which actually, wanted to explore which is the best, which is the best way or the best methods to train and to teach emergencies and disaster situation. And from this review, it came that the simulation-based training is the best option. Okay, this was, I would say that this is a step forward, because a review in 2004 actually was not able, and a meta-analysis was not able to, let's say, address which was the best one. So this gave us a little hints on how to proceed and go on. So simulation is the best option, and let's see what are the different methods that are available in the for all of us. So the tabletop is, I think most of you have experience in such a type of simulation. Anyway, this type of simulation, the intellectual and communicative environment, it's replicated, but not the physical one. So we work on pictures, we work on draws, and but by the way, we are a tabletop simulation allow a mix of face-to-face teaching with the addition of some practical exercise, which provide the learners with the possibility to put their gained knowledge, of course, in a limited practice. But at least they are very good instruments to achieve some specific learning objectives. And there are many different type of tabletop, from the very homemade version, the one that I presented in these slides. Actually, these are pictures printed on big papers, and we use this little draw to replicate and simulate personnel and means and goods, such as ambulance, and also the most advanced tabletop tools such as the Mergo train or the Maxime as another example, or this one, which is also available in the market, which came with the kind of all-in box that I can get and use ready to use. So the market, fortunately, it's full or plenty of this type of instrument. Probably I wouldn't say a more advanced, but a different way to do simulation training at tabletop in a way is the computer-based. So in this type of simulation, each or limited number of students has their own instructor, their own facilitator. The softwares that can be used are from the very sophisticated to the less sophisticated. Some of them are provided with some kind of artificial intelligence, some intelligent response system that suggests route to explore, control the speed of learning, and also provide immediate intuitive feedback. So these pictures actually report some of the training that we did, and we do at the simulation center. So the computer base, as I said, is a big range of options that gave the participants the possibility. I hope you can see the video that give the possibility to walk through the environment, walk through the disaster scene, and do some key actions. This is the example of how the participants can triage the victim, assign codes, and go and check for other victims. And of course, the advantage of this type of simulation is that people can work in a collaborative environment, distributing the roles, communicating each other and coordinating each other, but also, and this I think is the more advantage, this system provides the instructor and the participants with an immediate feedback. So, which we will see in a while, it's the more important step for make us change our behavior. So the example that I show is, again, it's quite a simple one because it works in a 2D screen, but we also have a more advanced now available more advanced simulation softwares that allow us to work in a more immersive environment using these head-mounted devices that gave us a more sense of engagement and a more sense of immersive. So we are really immersed in the situation, or again, even the more sophisticated and advanced such cave or low-cost cave that also are affordable and for the majority of the simulation center and the medical school, whatever. And we have also to consider now the the huge availability of augmented reality software and solution that are used either for the training in disaster situation and for the response in disaster situation, and we'll see in a while. So the instruments available are really huge, are really impressive. Another modality that we are used to apply in the disaster training is the high fidelity simulation. I guess again that you are all aware about what we're talking about. Anyway, this simulation provide, a range of diverse scenarios to learn, complex problem-solving situation, decision-making, and also resource and management and communication skill, I would add. So it's offer also the time and the capacity to reflect on what they have, what the participants have done, especially during the feedback or the debriefing time. But again, one of the most important advantage is that allows, as the previous example, the participants to, allows repetitive practice. So we can repeat and repeat and repeat until we gain some kind of standards. And of course, I wouldn't add that this doesn't harm anybody, because we work in a safe environment where my mistake is not has any consequence to patients. And this is an example of high fidelity scenarios that we conduct regularly in the training of our medical students and also our residents. So here the people are, the participants are exposed to a situation where there is a pregnant woman in during a humanitarian mission. So he fell down, and now the problem is to manage either the woman as the fetus. So they have to decide with the father, the husband, how to proceed in a place where there is no diagnostic resources available. So the closest one is 40 kilometers far away. And probably the last method in these big categories is the real size simulation, the exercise. And so the functional one, or the full scales. In this simulation, the emphasis is on the crisis resource management and the different aspects of the crisis, such as how to manage personnel, how to manage the whole resources, also how to manage time in this specific situation. So the aim is to establish the inter-individual, amongst individuals, but also amongst the different disciplines, so the different agencies, so interactions, by asking and receiving apps, which is the way we work normally in such a situation. And I think we are all aware we're talking about. And in this type of situations, simulation, we normally use two different type of simulation modalities. So the one, so this one, the high fidelity again, in a kind of a hybrid situation, or the what is called the simulated or the standardized patient. And this is an example of a medical student who was trained to act as a victim of a disaster situation. And you can see how well is behaving. But I have to say that being a simulated patient can be, I would like to warn him, because it's sometimes could be dangerous. These two guys are the medical students, the simulated patient. So after a disaster, you can see here there are the army soldier who are inviting to join the green area for where the patients are collected, the walking wounded are collected. So they are invited many times. So the two guys are playing their role. So actually, I would say they are very engaged in that role. And you can see in a while how then suddenly what occurred and how dangerous could be to be a victim. But fortunately, he tried to not to be hurt by the soldier. So again, this is a type of a modality of simulation training in disaster medicine, which is the most used one, I would say. So we recently have done, so if you are interested to read more about simulated patient disaster medicine training, you can have a look of this review that was recently published, and which explain how they are used and how they either in the training and in the assessment. And just to give an idea of how complicated, I didn't say, but of course this it's obvious how complicated it can be to organize such a simulation exercise. This is what we did with the residencies schools in anesthesia at the national level. So we gather all the almost 150 residents throughout the country in a small island in the south of Italy, and we organize at the end of this kind of summer school a huge exercise where they can apply their what we have covered during the skill stations and during the teaching session. So in that case, those guys faced migrants boat wreckage. And so how to, because this was a very hot topic a couple of years ago, and we want to prepare the workforce how to deal with this situation. Okay, but we have talked about simulation, but I actually have to say that simulation are important, of course, but they are important because they are an excuse to reflect on what has been done in the simulation. So the debriefing is the most important part of the simulation experience, of the training experience, for several reasons. This already demonstrated, is already reported in the literature in many studies, that learning does not occur in simulation-based education in the absence of debriefing. And of course, we can easily understand how difficult can be, how important it is to provide the feedback and reflect on what has been done during a simulation when we work in a skill station. But if you imagine how complicated is a full-scale exercise, and especially in this distributed environment where people that are on the scene that don't see what's going on in a hospital and vice versa. So having running a debriefing, it's more complicated, but it's still a key for the learning. So we cannot allow to do any exercise without a structured debriefing. And there are also techniques that help us to conduct this kind of reflection. So we have say, I think I try to respond to the question, how do we train health professional? Let's see, but why simulation is the response? Because, and I just report some input, WHO actually are asking, are demanding, I would say, the medical schools to make students to err, to do mistakes, to do errors, because it's only from the errors that us as health professionals can understand the mechanism that conduct to that result. And this, of course, cannot be done at the bedside. So we have to select to pick up analogous and something similar to the patient or to real situation, which are the simulator or the simulation. So it's very important for the medical schools to give the students the possibility to make these mistakes, to learn how to prevent them. And again, why? Because there is also, I mean, an evidence that medical students in disaster medicine training programs improved student disaster and, in that case, pandemic preparedness. And this improvement reflects in terms of improved attitude, knowledge, and skills. So this is a recently published a review conducted just after the first wave of the pandemic. So these efforts are effective, and I think this reassures all of the trainer, all of us. And also because training help, I mean, not only to, let's say, gain more experience, of course, but also to reduce the natural fear that we all as healthcare provider face when we are forced to deal with such situation. We did a study during the Ebola crisis in 2015, and we demonstrated that using simulation for not the healthcare students, but the healthcare professional already, so people already trained, actually reduced the fear and made the workforce more willing to be deployed and help. Because, I mean, this, I think it's normal. If I know what I'm going to expect, I'm going to be more, I wouldn't say relaxed, but I know how to behave. I know what I'm going to face. So now we have these instruments that allow us to replicate and reproduce realistically this situation and develop these mental schemes as the army does for the soldier in our mind that generate this automatic response. So I know automatically how to behave. And again, why we use a simulation? Because we use the same tools that are now in place in the response. So this is this review report how the augmented reality tools are used in emergency response, in disaster response, not the training. This is the response. You can see here the size of the squares and rectangular are report the frequency, how popular they are. So now the professionals, the workforce, the healthcare provider, the responders are using this type of devices. So if we use the devices in the training phase, we make our professional, again, more prepared because we use the same tools, really the same or very similar. So this is another reason why. Okay. I think we have addressed the three main questions, but now it's who's going to train? Because this demands time and efforts. So it's nice to talk, but in practical terms, who is going to be the trainer? And probably the professors are the most, the most suitable or the most appropriate. The teacher, so those who are, by the way, I would say paid for that. So, this is probably a message that I use to give to all the medical schools, having increasing simulation activities, including those related to disaster medicine or the mass casualty events, requires more time. So the workload of the teacher, of the professors, of facilitators increase. It's a matter of fact. And so sometimes those cannot be the response to this demand that we are facing now. So there are different options, and I would like to report some of the options to, not to replace the experts, but just to, that they can be combined to the experts' intervention. So there are these massive open online course, so that's called as a MOOC. There are different options. Probably some of you have already taken part in some of them. And so these are online training courses that in most of the cases are free of charge, open content, and when they require a fee, in the majority are very affordable for all. And I just would like to report this, this platform, the MOOC list, which actually includes a lot of disaster and emergency and disaster training MOOC provided by, different learning platform you can see on the right-hand side. And just to make an example, this one of the disaster medicine training opportunity, and that are interesting because they are developed by very known university in majority of cases. So this, for example, is designed and delivered by the Stanford Emergency Medicine Program, or some of them are designed by the Harvard Medical School, and so on. So they are very good opportunity, yes. And then there are the peers. So the peer education, it's already been demonstrated to be effective in different medical field and disciplines, and disaster medicine is one of them. This, for example, a study done by a group of colleagues from Italy, which were able to demonstrate that peers educators in disaster medicine training were very effective. So you students, myself, when I was students, we all could have a role, an important role. And then I would like to share an example that we practically did, and we are still running. So the research center partnered, in our research center, Primadim, partnered with the Italian Society of Medical Students, and we together design what we call a disaster CISM. So CISM is the society, they call it the name of the society, the association. And so the disaster CISM was the training course that we together delivered, and where the trainer are students, educator. So we train the students, and so we design now different modules. So from the basic, the advanced, and the last one, the disaster team, is the structure. So the TOT, the train the trainer program. And so the strategy was, as I said, the research center together with the Medical Student Association, we were able to, let's say, go in the different medical schools. So we designed a program which was a blended learning, which used the blended learning approach. So any learning phase, a peer-assisted learning time, then including a simulation and computer-based learning. And we were able to deliver the training. So the project actually started in 2008. So this is a kind of history, just for the records. And in 2018, the program actually won an awards in one of the most important Congress. But I have to say that also was adopted, and this is the very achievement by the International Federation of Medical Student Association. So the results so far are very, in my opinion, are impressive, because I started in 2008, where again, where I said Italy was facing the bad situation that I report, where no medical students had any chance to be exposed. And in the last year, we achieved 38 medical schools, sometimes more than once. We trained more than, when I say we, actually, I did only few training courses, because I trained the trainer, and the students, and there were the students who trained the other students. But in this way, we achieved 3,000 plus future physician and nurses to be trained. And the result in terms of learning effectiveness were very encouraging. So we increased the knowledge, we increased the awareness, and they were really appreciated by the students. And as I said, this training model was adopted by the International Federation of Medical Student Association, and now we deliver the TMDT, so which is a training program for the trainer at the international level, and then those peer-to-peer trainer are then deployed because in different countries, because they go back home and train their own peers. And if you are interested in read more about the Italian project, so you can have a look of this paper. And what we have learned, I think it's important to share that with you. So we have learned that students know what they want to know. That was from our experience, but also they know what they don't want to know. And students, love what they do. So, and that is, in my opinion, probably this is more a message for the senior people here, for the senior students, maybe if I can say in this way, senior students as you and I. So they love, and they are the tremendous vector of a message. So they really are very good when they train other peers. But also we learned that this is a short-term solution. This cannot be the long-term. So it's not the definitive solution. So we might work on the, let's say, the curriculum more in order to incorporate disaster medicine principles training in the formal curriculum, because this is still an optional thing. So I think we are approaching the end, and so the last question is what we have to train. So we said, okay, we say it's important. So why we train? How do we train? Why simulation? Who is going to be the trainer, and at what going to be the topics? And I go back in 2008, which already the American Medical Association of Disaster Preparedness convened a group of experts to review competencies and to achieve consensus on educational framework and competency set. And so from this experience, which almost date more than 15 years now, or more or less, so we can take already some important, messages or strategy. So the expert group, the group of experts, defined different categories, and for each categories, so they identify competencies in accordance with the Bloom taxonomy. So there might be categories of competencies that might be achieved by that specific category. And so mainly they reported the diversity of course, the expected job function and educational requirements. So, and if we take the model, we can define three main categories, and we can identify three main topics or level of training. So the medical students primarily, so they require awareness and understanding of disaster planning, mitigations, all the principles, with the limited ability and a limited need to apply this knowledge in the field. Although we have seen during the pandemic, while the pandemic situation occurred, that also in some countries students were incorporated in the workforce. So then there are the residents, which are required to apply clinical and public health knowledge, skills, and values. And finally, sorry, the leaders, the policymakers. So they might, of course, for those people, the decision-making responsibility, the leadership function, and the policy-making rules in disaster planning are the target of the training. So we can have different level of, and then again, our experience for all of them, we design a specific training program that I report to you because they are open at international students as well. So I don't talk anymore about the disaster team and the TDMT, so the trained disaster medicine trainers, and I go directly to the residency program. So the program for residents, which is called the Humanitarian Medic. This is a training that was designed with Médecins Sans Frontières, so Doctors Without Borders. And actually, I'm very proud, I would say, to have convinced I just would like to report an anecdote, my personal one. When I graduated, I would like to take a mission. So I applied for different NGO as a physician. So I wrote my CV at that time. I included whatever I could, but my experience was very limited. But I did really, I used different words to say something big, but of something very small, of course. And I sent all of them. So no reply for months. And then suddenly, some NGO from, I think it was Pakistan or India, replied to me that they were interested in my my profile, and they invited me to send them an extended CV because they required, they asked to know more details about my experience. Of course, I had nothing to add at that CV because I put whatever I could, even when I was responsible of the clock board in a disco music. So I couldn't actually add anything, but there was no way, just to say, there was no way for a young doctor to participate or to join a mission. So with Médecins Sans Frontières, we convinced them actually to hire young physicians, so residents, in their mission, but only if they were, let's say, undertaking a training program. So we designed with them 1-year program during the residency course. So they don't stop the residency program, but they do the residency. And during this period, we provide them with some online training. We organize with them clerkship, internship in some specific department, for example, maternal and child, general surgery, pediatric, GNO, gynecology and obstetrics. So those were very important. And then with the Médecins Sans Frontières, those guys are deployed in what they call the teaching hospital. So there are missions, let's say, established long-term. So not that they're not facing any recent crisis, but anyway, they are in a general humanitarian situation. And during this period, of course, they practice clinically, but also they gain experience. And then finally, they pass an exam. So the idea is to end the residency program with already an experience in the international field and become the perfect humanitarian aid responder once they are specialized, because they have already an experience in their background. And the program was very effective. Now are several years that we run it. And also what we witnessed was that these young brains increased the research activities in let's say, in the Médecins Sans Frontières environment. because smart, are intelligent, are willing to do new things. So NSA is one program. These are the main topic that we cover during the program, and we combined self-learning, distance learning, and high fidelity and virtual reality simulation. And then, as I mentioned before, the internship and apprenticeship in the field with the MSF. And these are some examples of what they do during the full-time high fidelity and training program in the simulation center. So this was a training lab for general surgery, and also we exposed them to different situations in crisis situation in collaboration with with some agencies. And then the final option before I conclude, I hope to be in time, I think to be in time, is the European Master in Disaster Medicine, which is for the leaders. So again, taking the model of 2008 American College, the American Association input, the European Master in Disaster Medicine targeting the leader in the field. It's composed by an e-learning activity, then 2 weeks of residential session, and then a thesis that might be accomplished by might be designed and written by the students, participants. It's 1 year. So this is a timeline of the course, and it's quite, I would say, affordable in terms of time, because again, there are a lot of space dedicated to the e-learning training, so we can learn at our own pace and in our own environment. So we don't need to travel. Unless the 2 weeks, the course is divided in 9 course unit, and it's very, wide and embrace all the main topic of disaster management and humanitarian aid. Is delivered by different organization, different university, and Accepte University is one of the partner, of course. So we're very happy to that. So concluding, and then I hope to have some space for questions. So training in disaster medicine is a need. I think we all agree. Simulation, and I emphasize and highlight the following the briefing, is the preferred or might be the preferred educational method. There are a lot of opportunity out there, so it's up to us to grab one of them. I strongly convinced that Pier DM disaster medicine education is a good option, and evidence actually demonstrate that it is. But of course, it's not the long-term solution. It's just short-term. And as I said, students and junior doctors can have also an active role in crisis situation. This is a big debate, actually, especially I mentioned it during the acute phase of the pandemic, and there are different opinions, but I'm mainly in favor of their possible participation. And I thank you all for the attention, and I hope to have been, not too late.
Thank you, Mr. Ingrassia. No, we're not late at all. So we have opened the forum so that the participants could send their questions to us, so that it's more organized that way. And we have received 4 questions, and just a second, please. Okay, then. The first question is, which branch of the medicine is more burdened and more impaired in cases of disasters? The first question comes from a participant, anonymous, please.
Thank you very much for the question. I think this is a very hot and tricky question. I think there is not a right response. I would say in disasters, the majority or most of the health branch are impaired. Of course, the acute one is the first wave to respond. I'm now thinking on emergency medicine, anesthesiology, radiology or diagnostic, but also surgery and internal medicine, for example. And but we don't have to avoid, or we don't have to forget that disasters are, in the majority of cases, long-term events. They are not, let's say, after the acute phase, we have to face with the result of disaster. I'm thinking now on the, for example, dialysis process that might go on, or the primary care that might be a guarantee to all population. Area affected by geophysical events, for example. So I wouldn't say there is one specific main discipline board.
Okay, thank you. And we're moving on to the second question then. The second question asks what the possibilities are for these kinds of simulations to be done or integrated to the real disaster fields. And the person gave Syria as an example. How applicable is such a simulation to be conducted in that specific field?
Thank also for this question, which actually opened, I would say, a new topic. So probably the correct answer is in the middle. I would say there are many, there are some training tools which actually take the born from the response tool. So those instruments are designed primarily for the response, and then are also used with the kind of training mode for the training. And these, of course, are, in my opinion, the best option, because people get used to them since they are, meanwhile they are get trained. But also there are many other software or application that are designed specifically for the training. Of course, they are very helpful because they achieve a result, but the design is completely different and then don't allow to be used in the response field. I was asked several times. I mean, the team I work with were asked several times whether the software that was used by us could be extended and used in the actual disaster response. We tried once, but we then realized, and this I guess is the lesson learned, that unless you design and develop the instruments with that aim in your mind since the beginning, you cannot achieve this result, because the design is completely different. And also the beta testing that you need to do, it's something long, it's a very long process. It's another job.
Okay, thank you. And our third question is, have you organized a training for biological disasters like the pandemics? If not, would it be different if we had organized such a simulation beforehand? And do you think that that rate among healthcare workers is related to being unprepared to a disaster like that?
Okay, so I tried thank you again for the two questions. I'll try to respond one by one. So the first one, if we have organized training for biological and chemical and radiological as one, I would say yes, we did. We participate also in a couple of EU projects where they were actually main focused on the chemical and the radiological, but also in general terms included the biological principle. So the principle on biological response on biological events. We haven't or designed and delivered specific training for events such the one that we started facing last year in this February. I mean, I'm referring to COVID-19, of course. So we hadn't done anything for them. We included, for example, either in the master and also in some of the training for residents, principles about pandemia. We did a training, actually, I'm now recalling, for H1N1 in 2009 for the hospitals, and we use the same. I mean, we use the same tools, but of course we design a different scenarios. So the one that I reported are different scenarios, and we actually, in that case, this was dedicated to the hospital staff. The learning objective was the hospital pandemic disaster plan at that time. I'm sorry, I forgot the second question. This, I think, is the result of my daughter woke up in the night.
No problem. And the second question was, could the death rates be lowered? Could death rates of the healthcare workers be lowered if such a simulation was implemented beforehand?
Well, in my opinion, the answer is yes, it could. As I reported, we did such an experiment in 2015 with a similar event. I'm referring to the Ebola crisis, and actually the threat probably is not lowered. So we couldn't lower the threat. We could lower, or we could reduce the impact of the threat, because in two terms, if we as workforce, health workforce, know what they are going to face, of course, we can react and respond better. And this makes me more confident, and this makes me more willing to do my best. And this one way. The other way, if I do my best and I do better because I'm more prepared, I can reduce the consequence of the threat. And that means a lower impact of the threat to the population. So we don't have to forget never that the disaster consequence is actually a combination of the disaster damage, the disaster response. Is never I can manage the threat, but if I have a volcano, the volcano is there. If I live in a seismic area, the threat is always there. I can make some intervention on reduce the impact. And we as healthcare workers can play a big role in this reducing process.
Thank you very much for your answers. These were the questions that were submitted to us. And I think that's all. We didn't receive any further questions as the others were being answered. So we thank you, Mr. Ingrassia, for your presence and very informative presentation. And we are going to have 2 more English sessions, and if you would like to join them on Sunday, you're welcome to. Other than that, the other sessions will be held in Turkish. But yes, and we're receiving some thank you notes from the chat, I think.
Again, I would like to thank you for the invitation. I really had the pleasure to join you. Unfortunately, I have to say I cannot join the entire session. So please forgive me for this. I would really have done, but I cannot. So thank you very much for the time we spent together. I really appreciate.
Thank you very much. And from now on, I'm going to continue in Turkish, if that's okay.
Thank you. Bye bye. Bye Melih. And bye all.
Okay. Tamamdır arkadaşlar. Herkese tekrar merhaba. Şimdi saat 12:03 olduğu için biz sonraki oturumun daha fazla geçe sarkmaması adına mola vermeden devam edeceğiz. Ve şimdi sözü Nursena arkadaşıma devrediyorum.